Hi. Hey, Jarvis. Thanks for being here.
Hello.
Let me make sure this is working. One second. Yeah. Hey, Jarvis. Thanks. There we are. Yep. So we are live on Facebook. Thanks so much for joining me. I'm excited to talk to you today. And I like to do a little centering before we start. So maybe we could do that. And then maybe you could introduce yourself more. You have so much interesting stuff going on. So for centering, I would just ask that people get settled wherever they are. If you want to get a little more comfortable if you're sitting, and you could have the eyes open or closed, it's up to you. And just notice your sensations in the body, noticing the feet if they're on the floor, seat in the chair, noticing the effects of gravity on the body, any other sensations that you perceive. Bring awareness to the breath, or anything you experience inside the body, noticing any feelings, thoughts, anything that's going on right now, and see if you can let them be without pushing them away. Allowing for this moment just to turn our awareness inside. Let's take a few slow breaths. And then slowly coming back, opening your eyes if you want. Okay. So Jarvis, thanks again for being here with me today. I really appreciate it. I know you're very busy, I can imagine.
Thanks for having me.
Yeah, I wonder if you don't mind introducing yourself, because you do so much and very different things, it seems to me, between yoga and research. Yeah.
Sure. So I'm a social epidemiologist by training. So I have researched for many years socioeconomic and racial ethnic inequalities in health. And I teach at the Harvard T.H. Chan School of Public Health in the Population Health Sciences PhD program. And then that's like one side of my life. And then the other side of my life, I'm an Iyengar yoga teacher and have been for many years now. But lately those two streams feel like they're converging. People in the yoga world are asking me questions about COVID-19, and people in the public health world are really stressed out and need yoga. So there's a lot of overlap these days.
Yeah, I hadn't thought about that direction, bringing yoga into public health, but that makes sense too. Yeah. Are you doing that? Are you teaching them? Are you teaching them?
Not at the moment. I mean, I have in the past done things, but people are, I've just been noticing that people could use a little yoga. Like I was just thinking, I've been interviewed a number of times now in the last few weeks for various things, and I wish all of my interviews started with centering. I think they would go really differently if they did.
That's why I do it. You know, I often have the guests lead it, which is fun for me. I get to hear different styles, and it helps me, it helps me start something and be more present with this experience. Yeah, we should start everything with centering, like in yoga.
Yeah, no, that's right. I think it's particularly urgent right now because, people are really stressed out. Having to make decisions is a really stressful thing right now, and that's part of our situation. Like the fact is that there's so much we don't know about the current pandemic. While we have some ideas about what's safe and what's not safe, we don't really know, like all of the individual decisions we make, what the impact of those things are. So that's exactly like an urgent decision that has to be made, not enough information to make it, really high stakes for us, really high emotional consequences. Like it's no wonder we're stressed out about it.
Yes. Yeah, I think also social distancing has stressed people out too, changing of lifestyle and yeah, and then the intensity of the news and then everything else going on right now, culturally with Black Lives Matter and kind of the stress, excitement, and kind of adrenaline of that. I think it just feels like a lot. I mean, it's such an intense moment for us.
I was looking, I was on a webinar that the Census Bureau did recently about this household pulse survey they're doing, which is every week they take a probability sample of the United States and ask a number of questions about how people are handling the pandemic and the situation that we're in. And what they found most recently was like 35% of the US population is experiencing symptoms of either anxiety or depression or both. And that's in comparison to in previous years for around this time period of the year, like it's usually 11% of the US population.
Wow. And you said 35.
35.6% of the population in the most recent week of data they have, which is for the end of May. And so whenever I'm in a situation where people are telling me like how stressful it is to be just thinking about like, what should I be doing? I think about this fact that, right, we're all under significant emotional stress right now. And so it's really important that we have the tools of yoga to try to help us center, as we did at the beginning of this webcast, and just like get to a place where we might be able to put a little bit of space between our thoughts and our reaction to our thoughts.
Exactly. And it feels like it just keeps happening. Like this moment it keeps extending. I think part of us, at least for me, I could speak for myself. I think I can handle this level of stress for a certain amount of time, but then you expect it to end, and it just feels like things are getting longer and more intense. I mean, that's what my experience is. Like things aren't necessarily getting better with the virus. It seems like we're just maybe getting into a place of denial or something. I don't know what it is.
Well, I think that we do. It seems like we have a little bit of a moment's respite at the moment, in the sense that, we in the US, we instituted these pretty dramatic sort of shelter-in-place shutdown policies. I mean, there was a lot of variation across the country in how those were enacted, but by and by, in the cities with the sort of largest epidemics, those seem to have been successful in flattening the curve, in cutting down transmission. In many of those hard-hit cities like New York City and other places, the basic reproductive number, if you've heard about that, this idea of like the number of secondary cases that every case causes, seems to have fallen below 1. And so the shutdown was really successful in a lot of places. But then that means like we're now in this place where we have to think about, okay, what can we relax? What do we have to maintain? And that's really challenging to figure out.
Yeah, I feel like because it was successful, maybe I feel like it's almost like there's a paradox there that people think, oh, it's not really so bad. We can get back to normal faster, I guess. So I'm just wondering if there's some complacency because of that success, rather than realizing that we have to continue to be careful.
So, yeah, I mean, I think this is where there's so many different sources of data to take into consideration. So while the shutdown was successful in many places in preventing the healthcare system from being overwhelmed, and we have really knocked back transmission to a great extent in many places, it's also true that the most recent data suggests that really, even in the hardest hit places like New York, maybe 16% of people have antibodies to the novel coronavirus, which means that there's still a large proportion of the population that is susceptible to infection. In Boston, it's more like 13%, or in Massachusetts, more like 13%. But that means there's a lot of people who could still get this virus. And that's why we have to think about like what are the most effective strategies for mitigating that risk, even as we recognize that like really dramatic shutdowns are kind of a blunt instrument and are really not easy to maintain over a long period of time.
So could we talk about reopening yoga studios? I mean, I think I know it's happened already in many places. And I know a lot of places, like I'm in Santa Barbara, California, and I believe in California, we just got word as of today, actually, that yoga studios could reopen. We're like the last group of businesses that could be open in California. Or maybe not the last, maybe second to last. I believe the last will be like large gatherings, but the second to last. And I think it's today. And so I've talked to a few studio owners who have different feelings about it. The studio I'm involved with, the teachers don't want to come back yet anyway. So, so the owner was willing to open, but the teachers aren't interested. So that was interesting, I thought.
I think there are a number of issues to take into consideration. Yeah. So, I think that as a number of my colleagues have talked about, we probably need to stop thinking about there being one epidemic in the United States and really start thinking about the fact that there are multiple epidemics going on. Some are large, some are small, some are ongoing already, some have yet to start. And so there are going to be many sort of mini epidemic curves happening in different places. Yeah. And so the decision that people make may have to be influenced by what's happening locally in terms of, are the numbers of cases increasing in your area? Are the number of positive tests increasing in your area, even as the number of tests is going up? Because that would be a real indication that transmission is happening. And so, the fact is that if the overall probability of you encountering an infected person in your daily life is small, which it could be if you're in an area of the country where there hasn't been a lot of transmission and people aren't traveling into your area, it may in fact be safe to be in an in-person yoga class. And we have to talk about what that in-person yoga class looks like. But just sort of overall, taking into account the overall prevalence in your area is really important as well. And then given that you are going to a yoga class where people might be infected, then the question comes in of like, what is your risk of being in that class? So what we do think we know now from the science is that the real large risk of infection is coming from being in an enclosed space with strangers for longer than 10 or 15 minutes in the absence of face coverings, etc. So it's that being in an enclosed space, because most of the transmission is through droplet or aerosol transmission. So when people cough, but also it seems like when people sing or when people are talking loudly, that there's a lot of droplets being kind of thrown out, and that if you breathe that in, that's when you can become infected. Obviously, if you're in an enclosed space and the ventilation isn't great, there's going to be more of a chance that you'll pick up one of those droplets. That effect can be really mitigated if you if the person who's infected wears a mask. To some extent, it can be also if you as an uninfected person is also wearing a mask, although that would have to be like an N95 mask or something. Cloth masks are probably not doing a lot, but cloth masks do block someone who is infected from coughing in terms of transmitting the droplets. So I think that's the really big risk of yoga classes. The CDC now seems to think that picking up droplets on your hands from touching surfaces is probably not as important a route of transmission, although disinfection is really important, and as is hand washing. So for me, the crux really comes into like, how do I feel about being in a room with other people for longer than 10 minutes? And most yoga classes are longer than 10 minutes. So I think that's the challenge. Now, what people are doing is also saying, well, if you can maintain physical space between you in a yoga class, a minimum of 6 feet. But some places, like I know Rhode Island is saying, if you're in a group, like in a group fitness situation or in a yoga class, and people are not wearing masks, they're requiring 14 feet of space.
Oh, wow.
I know very few yoga studios who could have more than 3 or 4 students if they maintained 14 by 14 square feet around each person.
My gosh.
Yeah. So I think that's the real challenge. I do think that, so the other piece to take into account is, okay, if you are exposed in a particular setting, like what is your personal risk of developing either severe disease, needing to be hospitalized, or dying? And what is that risk? And that certainly increases with age, and it increases if you have any other chronic health conditions. So there's that risk to yourself. And then the final piece of that is also, what is your risk to people you care about in your life? So it might be okay for you to be in the yoga class, but if you care for someone who's immune compromised or is an older parent or something like that, the consequences can be really serious. So you have to take that into consideration. For me, for many of my students are older. I'm feeling not so young myself these days. So, I think for many of us and many teachers I know who are over 50 are like, this is more than I want to take right now.
Yeah. And I know that maybe we could talk a little more about that, but I'm interested in the health inequity issue too. I mean, that's your research about the racial piece. It's racial and economic status. Is that correct?
Let me just say one more thing about the kind of risk assessment calculation thing, because so I think you and I share some history in the sense of like, this is not my first pandemic. And so one of the things that many of us who worked in the HIV pandemic learned about is the concept of harm reduction, where, when we have to make behavioral decisions, we're often weighing risks against the things that bring meaning to our lives. And so, we need to think about that, like what risks are we willing to take in order to have a fulfilling life? And I think that that's where the kind of the weighing the risks and benefits of the actions we take really matter. And also thinking about what are incremental steps that we can take to reduce our risk, even if we don't fully eliminate our risk. I think what makes this particularly difficult right now is because it's so contagious. The decisions that we make impact us, but it also impacts people around us, both the people we know and the people beyond our immediate close social networks. It affects many communities. And so this is where this kind of dovetails with some of the research I'm doing, which is that we're really seeing that COVID-19 has had a disproportionate impact on communities of color, on socioeconomically disadvantaged communities. And so we really have to think about how our actions can impact those communities. Those communities are the people who are often essential workers, so they don't have a choice about working from home. They need to leave the house to work in public transportation, they work in grocery stores, they're often the people who work in healthcare, who work in nursing homes. And so to the extent that we can not contribute to ongoing risk of transmission, it also has an effect on those communities. What we've seen in many of the analyses that we're doing is that there are these huge racial ethnic disparities. What's really stunning in some of the recent work we've looked at is that those racial ethnic disparities are even larger among younger ages. So that in the younger ages where the risk of death due to COVID-19 is much less, what we're seeing is that Black folks and Latinx folks have risk of dying, which is like 5 or 6 times that of non-Hispanic white folks. And in fact, that's true over all racial ethnic groups. Asian Pacific Islanders also have a relative risk of dying that's like 2 times, and American Indian Alaskan Natives also have a dramatically increased risk at these younger
ages. Can you just clarify it for me? So when you say greater risk of dying, is that they're more likely to get infected, or once they are infected, they're more likely to die from the infection?
So we think both of those things are playing a part. So it's both the risk of infection, given that folks are working in essential jobs. They're working in situations where they might not have access to personal protective equipment.
Right.
And that also they're living in housing situations where they might not be able to isolate from the other members of their household.
Mm.
And those things contribute to increased risk of being infected in the first place. But then we also know that people who have chronic health conditions are at increased risk of dying. And what we also know is that race and racism are very much associated with increased risks of diabetes, obesity, hypertension, heart disease, asthma. So a large number of chronic health conditions have been linked to experiences of racial discrimination and also socioeconomic disadvantage.
Yeah, I know that happened with AIDS too. I mean, that HIV moved kind of from the gay male community to minority groups. I mean, it seemed like it was.
Yeah. And we've seen some of that in some other analyses we've done looking at excess mortality in Massachusetts. We've seen some indication that, so one of the ways we can see the effect of COVID-19 is to look at the number of excess deaths we see in 2020 compared to previous years. And what we see in Massachusetts is that surge starts earlier in more affluent areas. So areas with lower percent poverty or lower crowding or lower kind of racial ethnic composition, more non-Hispanic white, we see some indication that the surge in cases started earlier. But then when things really take off in more disadvantaged communities, they really take off in terms of excess mortality. So it's a situation where we see that the unequal sort of the racial equity or racial inequity situation in the United States is compounding these patterns of inequality, so that people were already vulnerable and now they're really being devastated by this epidemic.
And this is your work in general, right? I mean, this is the work that you're generally teaching about. And so previous to COVID, you were working in cancer research?
Yeah, so we've worked in cancer, in premature mortality. We've also done some work on gun violence and many other outcomes. I mean, part of what my colleagues and I have worked on starting 20 years ago was something called the Public Health Disparities Geocoding Project, which was a project to try to address the fact that many of our health surveillance data sets in the United States have no information on socioeconomic variables, even though we know that socioeconomic position is a strong predictor of health outcomes. And so we developed a methodology where you can use people's neighborhood, like where people live, to characterize the kind of neighborhood conditions that they live in. And this is related to the fact that in the United States, where people live is strongly segregated, both racially and socioeconomically. So people are really, where they live is a strong influence on their health outcomes and the way that they're able to manage their lives with respect to work and with respect to leisure. And those things are such strong determinants of health.
So you're okay. So that's what I was wondering. So there, where you live, is a predictor of health and inequities, according to where you're actually located. It's so interesting to look at it that way.
In so many ways, like it's related to who lives in certain neighborhoods, the kind of jobs that they have, etc. But it's also related to the environmental things that people are exposed to. So some of our group has also done work showing that people in poor communities experience higher exposures to air pollution, to black carbon and PM 2.5, which are these small particles that when you breathe them in can really affect your heart and lung health. And then also green space. So poor communities, particularly in urban settings, often have less access to green space. They experience more heat in the summer because of the way the urban environment is built. So across a wide range of exposures, the experiences of people living in historically disadvantaged communities is really has a negative impact on health.
Yeah, I heard that about, was it asthma rates and proximity to like the shipping areas, like in places like Oakland, California, or in Los Angeles, that there are increased asthma rates and in minority groups that live near those ports.
Mm-hmm.
So maybe that's what maybe that was related to one of the things you mentioned about the air particulates or something. But
Yeah, I'm not familiar with that work, but that
yeah.
sounds likely to me.
Yeah, that's interesting. And I mean, it connects to me with the work we do in accessible yoga, because we try to talk about, access to yoga teachings. And I feel like it's not the same, but I could see like you could also say there's a lack of wellness practices, or things like that are available to people in those communities as well,
Yeah.
because it's more of that. Yeah.
Yeah. So actually, some of my doctoral students are working on these issues. In particular, one of the difficult things about this work is feeling like all we do is point at the negative aspects of these communities. And
Yeah.
actually, at the same time as there is structural disadvantage that people in these communities experience, people in these communities also are wonderfully creative and resilient at coming up with things from within the community that try to promote health. And so, some people that I know that I work with are working on things like urban community farming and ways of creating access to healthy fruits and vegetables to help people with their diets. People are working on environmental justice issues and things like that. And so those are really important too, the work that communities are doing to try to improve their health. At the same time that we have to recognize, how pervasive structural racism is, and the fact that it's an uphill battle, given the ways in which so many of our society's structures are kind of engineered to create disadvantage in those ways.
Yeah, I mean, so really maybe this is beyond the scope of this conversation, but it seems like the whole racial justice movement that's happening right now is really directly related to the epidemic. And it feels like it's two different things, but it does seem like they're so closely connected because of that, because of these deep injustices that have been happening for so long, that are, like you said, structural in the way where people are living, the kind of jobs they have, access to food, things like that.
Yeah,
Yeah.
I mean, I think that these issues were always super urgent, but I also think that in the midst of this epidemic, the really brutal events that happened to George Floyd and Breonna Taylor, I mean, I think those really they kind of precipitated a thing, given that our communities were already so affected and so kind of devastated, that it galvanized the whole movement. And so hopefully that's a positive thing that's arising right now.
Yeah, because it sounds like your work has been pointing that out for a long time, the systemic issues and how they relate to, health and illness and death, which is amazing. I mean, it's amazing to have hard numbers and research on that to be able to show the world like this is systemic and we can prove it, because I've literally heard people say that it's not true. I've heard the kind of whatever arguments going on, and it just seems like your work would be helpful in showing like actual death rates and how they're connected to.
It's challenging. I think those of us who work in public health are often challenged to think about, if all we do is document these things and we never do anything to actually change these things, that's a trap that we have to be very careful about. And this is where I do feel like yoga makes a difference to me, because I think that practice of kind of stripping away the ego and stripping away attachments and aversions helps me see much more clearly what is the action that needs to be taken. Particularly, as I said at the very beginning, when it's so overwhelming, there's so much going on, it's hard to figure out what the right action is, and yet action needs to be taken right now.
Yeah. Yeah. I mean, it's an interesting field of work that it seems like it's getting so much attention right now. Like, I'm not sure that epidemiologists were ever given so much attention as they're getting. But
they're definitely having their moment.
Yeah. So that's exciting, I'm sure. I'm glad. I mean, I'm glad for you, and I really appreciate.
It's also a little terrifying because, it's interesting. Like this past week, the New York Times published a survey of over 500 epidemiologists from the Society of Epidemiologic Research, asking them kind of on a personal basis, like when would you feel comfortable going out in public and doing certain things given COVID-19? And to me, what was really interesting is though there was consensus about a lot of things, there was also a lot of difference of opinion. And so I try to be really upfront with the fact that I don't know the answers either. Like I have access to the same information. I'm trying to process it and figure out like how to weigh different pieces of the information. And what I try to do is to be really transparent about the fact that it is a process. There is this not knowing the answer, but we're trying to make the best that we can with the information we have at this moment.
Right. And I mean, can I ask like what led you into that work originally? I mean, how you got into the, not just maybe epidemiology, but into this question of the racial differences and the inequities that exist in health and illness?
Well, when I came to public health school, I had already been interested in the questions of racial, ethnic inequality and issues of class. And because I, went to school in the Department of Social Epidemiology at a time when social epidemiology was kind of taking off in the United States, that's where I kind of gravitated. And I worked with mentors who also are deeply involved in this work. So I've been doing that for some time now. I did come out, I came to public health in part because, again, not my first pandemic. I came out of doing community-based work in HIV prevention, in particular harm reduction work with injection drug users. In the 1990s, I worked on needle exchange and things like that. And so when I went to school for public health, I thought I was there to quickly get an MPH degree and go out back into the community and do work. But I ended up staying around and getting a doctoral degree and kind of broadening my research interests beyond just HIV.
And how about the yoga? How did that get involved?
And that happened around the same time because I was I was a doctoral student, and this fellow student of mine said, you're really stressed out. You should probably go to yoga class with me. And I thought, well, I don't know, but okay, fine, I'll go to yoga class with you. And that was the end of that because I just was obsessed with it from that moment onward.
Okay. Wow. That's awesome. And always Iyengar. Was it always Iyengar?
I mean, I dabbled it a bit when I was first in the yoga world, but I did settle quickly to Iyengar yoga in part because I met my teacher, Patricia Walden, and then it was that teacher-student relationship that was really important to me.
Right. Yeah. So do you feel like there's a connection there between those two parts of your life, between the research that you're doing and the yoga?
Well, I think we're being challenged to think a lot about this right now. I have colleagues who are deeply concerned about racism within the yoga world and the fact that, at least in the West, yoga has been kind of subject to colonial appropriation. And I think those are really real concerns, and the issues of representation of people of color in different yoga communities is a really important issue to work on, including how is it that there's a kind of cultural set to the way we practice yoga in the West that is not necessarily very welcoming to other people from other kinds of communities. So at the same time, I think that for me, it's a little more complex in the sense that yoga is a worldwide experience, right? I mean, there are many manifestations of yoga around the world, and certainly there are many people in Asia practicing yoga who are decidedly not white. I think there could be a question about whether the way that yoga came back to Asia has also promoted a kind of commodification of yoga in different ways. But I do think that certainly, when I go to the Iyengar Institute in India, I don't feel that it's a white-centered place. But I think but that's my personal experience, and I think it's important right now that we be able to listen to what different people's experiences are of yoga, and consider that if we are a community who support each other in spiritual practice, and also are interested in looking beyond just the outer manifestation of the person, we have to grapple with the ways in which we have made the practice not inclusive. So
yeah. Well, that's a lot that we're trying to do that in accessible yoga. I mean, just try to highlight and lift up other voices so that people can hear those different experiences. Especially right now, I think it's really interesting to hear the experiences of Black yoga teachers in the U.S. and around the world. But it's something we've been talking about for a while at our events, at our conferences, for sure. And it's something I'm very interested in. But I just want to say to anyone watching, questions. I want to invite people to type their questions in Facebook if they haven't previously. Sorry, go ahead.
No, just to say that, I mean, this is the issue of the moment. I mean, hopefully it will extend to beyond this moment. But I mean, the same thing is happening in academic public health. I mean, there's an urgent need to lift up the voices of Black researchers, people who are working at the front lines of anti-racism in public health, and to recognize that the structures of academic science, not just public health, have always privileged, certain kinds of cis, hetero, white male voices, right? Like this is this cuts across so many of our areas, and something that hopefully there's now energy to really address in a substantive way.
I know, I hope so. I was just hoping if people had questions for you that they would ask them. But I want to just go back, if we have time, to the question of reopening. I just feel like maybe there's some more topics there that would be. I mean, I have a couple questions, I guess. One is, I'm curious what you think about outside classes, because I've heard people moving their classes outdoors, and it seems like you basically address that by saying the main concern is being in an interior small space, or not small, but an interior space that for a longer period of time. And so it seems
I think that's a great idea. Like when I look at it and I think, okay, so if I were to apply a harm reduction lens and say, okay, I think it's really important to get together to do yoga. Something happens in the in-person yoga experience with the teacher that isn't captured in the online experience. I'd say, all right, I really want to be together, but does that mean I need to be together in a closed room? Or is it possible that we could be together but outside?
Yeah.
Is it possible that we could be together and outside and far enough apart that we don't have to wear masks? If you feel like masks is really difficult to do, probably being outside, it will mitigate the risk of kind of being together enough that masks won't be as needed, for example.
Right.
I think that's a good idea.
And then I know you mentioned that surface contact it doesn't seem to be as important as just droplets in the air, but I wonder what you think about the use of props, because I know in Iyengar teaching, as well as in my teaching, there's a tremendous use of props. So I just was curious what you think about that. I mean,
so I think that probably it is okay if people bring their own props, and they're using their own props. There's also like this subtle question of, well, not so subtle, but like this important question of like hard versus soft props. I think initially we were unsure what the deal was with soft props, but it seems that virus lasts for a shorter amount of time on a soft prop than on a hard prop. Although it does take, I think it still takes 3 days, I think.
3 days. Wow.
Yeah.
Like on a blanket. Also, it's harder to clean unless you wash the entire blanket, I would think.
Right, but I think if you put the blanket aside for 3 days, it's probably good after that.
Okay, but a hard prop could be washed, right?
A hard prop could be wiped down with some sort of wipe that has bleach or whatever. That would be best. And I do think that if people are bringing their own props and they keep their own props on their own mat, it's probably fine. Obviously, being outside would be better. The other thing, and this is, we really have to do more research to understand this, but one of the kind of the mysteries of coronavirus is the fact that that it seems that many of the transmission chains seem to just kind of fizzle out, like that, any one case may not give rise to that many more cases, but we have these super spreader events. And so
today, can you explain that a little bit? I don't.
So, it's the kind of like clustering of cases, and that might be due to differences in viral load and how much people are shedding virus. It might just have to do with the dynamics of transmission. But what it suggests is that then maybe what we need to think about is how to limit the sizes of gatherings so we don't create super spreader events. So I think part of the rationale of keeping the number of people low is not just that obviously with low numbers you can have more space between you in a yoga class, but it's that if anyone, right, because like people are coming to class and you probably should screen them. I think like the most important questions are like, have you lost your sense of smell or taste? Do you have a fever? Do you have a cough? I think if you, though we know that there's asymptomatic transmission or pre-symptomatic transmission, if you were to catch those people and those people didn't come to class, you probably would reduce the risk of exposure significantly. And then if the group of people is small, like under 10 people, even if someone got through and someone got infected, you might infect 1 or 2 other people, but you might not infect like 20 other people, or, as happened in some church settings, like hundreds of other people. So I think that's something to think about, is whether you could have yoga classes that were small, or whether teachers could switch to doing more private instruction or instruction with groups of 2 or 3 people. Similarly, things that to think about are like, is it possible that you could create a group of people with similar risk management styles who agree to get tested together, and then they stay together as a group of practice partners with the teacher, and they're really clear, if anyone feels sick, you don't come to class, and if you feel like you're exposed, you tell everyone in your group. Again, not my first pandemic, so people did these things.
That sounds like it.
Well, right?
Yeah, no, that's funny. I remember those kind of things. But I assume you're not going to be going back to teaching yoga soon. Is that true, in person?
I personally feel like so many of my students are older and would be at increased risk. I feel like I don't feel very comfortable with that. I'm also fortunate in that I have a day job and that I'm not dependent on yoga teaching for my livelihood.
Yeah, because I think of the challenge with what you're suggesting around reducing the numbers is for, to make money. As you know, most yoga teachers, you need more students to make money. And I think, especially for studios, I think teachers maybe can switch to more of like the model you used, a private or small groups. I think there is an opportunity for teachers to make money in privates that's, but it's not really there for studios. So it seems like, I'm just guessing that there'll be pressure from yoga studios to reopen more than from teachers, because teachers can teach online or do one-on-one in-person teaching, which feels safer to me than large groups. I think our studio model it's not designed to work in this way.
One of the things that our regional Iyengar Yoga Association did early on is because we recognized that teachers were really going, and studios were going to really be economically affected, is that we put together a grant program. And we asked people to propose innovative projects to transfer their teaching online. And we supported those projects because we really felt that as a community, we wanted to support teachers in being able to adapt and change the way that they taught in ways that would kind of just be responsive to the reality of the pandemic. And I do think that there's a lot more that we can do to think about, like, what exactly is the value that we give as a yoga teacher? Is it just that you come for an hour and a half every week to this room and you move around, or is there something else is there more to it that we do, and can we communicate the essence of that without having to be in a room with a bunch of people, or without having to be in a room with 40 people, or are there ways that we can think outside of the box?
Yeah.
And I think that we see this in the restaurant world, that some restaurants really quickly transitioned to doing takeout, doing catering, selling pantry items, finding different ways to adapt, and then other restaurants didn't.
Yeah.
And I think the same thing, unfortunately, is happening in the yoga world as well.
Yeah, it's true. I mean, also a lot of our community that teaches in the accessible yoga community, a lot of the teaching happens outside of studios as well, and maybe in nursing homes or in schools or in prisons and places like that. And obviously, most of those teachers are not able to go back to work at this time, but I have a sense that eventually they will. I mean, those businesses don't rely on the yoga; they're bringing in the yoga as like a supportive thing. So I'm hoping that work will still be there for those teachers eventually. I don't know when.
Yeah, I mean, I hope it is too, because as we open the conversation with this data on depression and anxiety in the U.S. population, there's such an urgent need for it.
Mm-hmm.
Yeah.
It really is. Well, I mean, I appreciate you so much for what you've been sharing. I don't know if you have any other thoughts you want to share with us. It's also intriguing, and I think your work really, you're like right in the middle of this moment. Like what you've been doing, it's just like, at least in my world, I mean, yoga and the pandemic and racial inequity. I mean, those are all the conversations we're having right now. So
yeah,
I really appreciate that.
I think that, I just come back to the fact that none of us know what the future holds. I mean, most of my infectious disease epidemiology colleagues won't even now commit to how long is this likely to last. It could go on a year, it could go on 2 years. There's a lot that's not known about when we'll get a vaccine. There's a lot that we still have to learn about, as we relax shutdowns and social distancing, what things are going to have the most effect in keeping us safe, and what are the things that we have to let go of. And because I said that it's really difficult making these decisions, particularly when the emotional stakes are so high, this is where I feel like community is so important. Our ability to talk to our colleagues, to listen to other people who may have a different risk assessment, a different harm reduction framework than us. That's really important, that we be able to do that and just support each other in this idea that we're all trying to make sense of a situation which is unprecedented for us and is going to be ongoing for some time.
Right, and I mean that's why I started doing these conversations a few months back, because I felt like I started feeling anxious and panicky, and I wanted to talk to people about what they were doing and how they were feeling, and this really helped me. And I think it was useful for other people to listen in on these conversations, because I mean, there's just so many different experiences, but I think we can relate to a lot of each other's experiences too. And that, like you said, that feeling of connection and community can keep us more grounded and not get lost in our anxiety and worries, because it is such an anxious time. Yeah, I mean, I wasn't going to talk about the length of the time. I didn't want to bring that up because I just feel like that's not a fair question to ask anyone. But I'm just, since we mentioned HIV and AIDS, I just want to say, when I'm feeling really concerned, I think about how we still don't have a vaccine for HIV. How many years now are we? I mean, 30 years? So I guess sometimes I think when people say, oh, we want to have a vaccine for
40 years next year.
What?
Won't it be 40 years next year? 1981.
Yeah, I think I'm older than I.
No, that's right. So what we saw is HIV profoundly changed the world and profoundly changed the ways in which we relate to one another and how we relate to one another, even as it did not change the fact that we are humans, that we crave connection with other people, that we want to be able to show, to give and receive love, that we have aspirations, that we form families and networks of friends. I mean, those things did not change, but the ways in which we had to negotiate them, the way we had to practice those things did change. And so in the same way, life as we know it is changing, which is the nature of Prakriti and the nature of material existence. And so, yeah, that's the link for me.
Okay, well, maybe we could leave it at that. I think that's so beautiful. Thanks so much again. I really appreciate it. And
thank you. This was great.
I hope, I hope you don't mind if I ever reach out to you again, because now I feel like you're this amazing resource that I'm in direct connection with. So I hope that's okay. Yeah. I love knowing people like you.
Yeah, well, the feeling is mutual.
Okay, good. Because often I just make things up and then I think, wow, I should really ask. I said, ask someone who really knows. Someone who really knows what's going on. Anyway, Thanks so much. All right.
Thank you. Yeah.
Okay, bye.
Bye.